Hi, my name is Linda Steinberg, and as president of the National Council of Jewish Women of Canada, I welcome you to our webinar on ageism in medicine. Recognizing the fact that our program in many cases will occur on the traditional territories of the First Peoples, we would like to acknowledge that this is a sign of recognition and respect. Such a statement supports the protocol that is customary when one First Nation and another meet on or within the traditional territory of a First Nation. National Council of Jewish Women is comprised of 5 sections across Canada. It's the oldest Jewish women's organization in Canada and the only Canadian Jewish women's voice on the International Council of Jewish Women, an organization with 35 affiliates that share common goals and concerns of women. Defining the impact of ageism is one of the pillars of NCJWC's, as National Council of Jewish Women of Canada's, vision for the next few years. It is a complex subject which truly affects all of us. Today, it is my pleasure and honor to introduce our renowned speaker, Dr. Samir Sinha. Dr. Sinha is the Director of Geriatrics at Sinha Health System and the University Health Network in Toronto, a Professor of Medicine at the University of Toronto, and the Director of Health Policy Research at Toronto Metropolitan University's National Institute on Aging. A Rhodes Scholar, Dr. Sinha is a highly regarded clinician and international expert in the care of older adults. In 2021, he was appointed to serve as a member of the Government of Canada's National Seniors Council, and also recently led the development of Canada's new National Long-Term Care Service Standard. We congratulate Dr. Sinha on his most recent honor as a recipient of this year's Canadian Medical Association Award for Political Advocacy. The CMA recognizes Dr. Sinha's work and effort to demand a national senior strategy from the federal government, and his notable political advocacy work in leading the National Institute on Aging, while shaping government policies on long-term care, caregiver support, and vaccination. Dr. Sinha, I give you the floor. Thank you.
Thank you very much, Linda, and it's a real honor to be with everyone today. June is Seniors Month in Canada, and so it's terrific that the council is hosting a webinar to really look at an issue that sometimes people want to shy away from, and that is that of ageism. So I really want to commend the council for wanting to kind of host a dialogue that allows us to look at the issue of ageism in medicine. And speaking of medicine, and speaking of the work that Jewish women in Canada have been doing, some of you may be aware that Mount Sinai Hospital in Toronto, this is its 100th anniversary. And if you know the story of Mount Sinai Hospital, it was started by a group of dedicated Jewish women. And so it's a real honor. And so therefore, when I got the request to do this talk, the only answer was yes. And so it was a matter of just scheduling a time. And it's a real honor to be here. So I'm going to try and even speak for less than 45 minutes so that we have lots of time to dialogue today. But I want to walk you through this topic about ageism in medicine and what we can do about it. So what is ageism? This is ageism. It's also known as age discrimination, and it really refers to the stereotypes. So how do we think, prejudice, how we feel, and discrimination, how we act towards others or oneself based on age. And while we've all heard about racism and sexism and anti-Semitism, for example, ageism itself was not even a word until the 1960s. That's when it was actually coined as a phrase, when we recognized Robert Butler in the United States, really coined this issue that seems to be one of the last acceptable isms in our society. And you can see age discrimination kind of playing out in a number of different contexts and environment. I just show you a picture here, of a common, play, saying, are we, do we tend to hire younger people versus older people? Is that considered a form of age discrimination when we might actually start thinking and feeling that a younger person might be smarter, might be more capable, might be faster? These stereotypes that we have that may allow us to unnecessarily discriminate against an older and potentially more qualified candidate as well. You'll also know that when we talk about ageism, we don't talk about discrimination, if you will, against older people, because ageism can cut both ways. You may remember when you were younger, you might have been told you don't have enough experience. For example, you're not old enough to do X, Y, and Z. And so is that a form of reverse kind of age discrimination? But the key is ageism is something we see more with older Canadians and older people in general, but it certainly is a concept that can cut both ways. So when we think about ageism in the Canadian context, we know that 1 in 3 Canadians admits that they have been treated differently because of their age. And when we actually look at that even further, when we think about older Canadians or older adults, 63%, about 2/3, have said that they've been treated unfairly or differently because of their age as well. And about half of Canadians agree that ageism is the most tolerated social prejudice versus gender or race-based discrimination. So again, why is that? Why has it remained kind of one of the most acceptable isms out there? And it's something that at least half of Canadians feel that it does remain kind of the most tolerated prejudice around. When we further think about ageism in the Canadian context, we know that 80% of Canadians agree that older adults are seen as being less important and that they're more often ignored than younger generations. We know that for younger generations like Gen X and Gen Y, they're more likely to think of those who are 75 and older as being dependent or frail, confused or forgetful, and even grumpy as well. When we think about, as well, just Canadians in general, 35% admit that they've actually treated someone differently because of their age. And so again, how do we think about these issues as well? So when we think about ageism, what does it look like? Well, there are 3 most common forms of age discrimination faced by older Canadians. And those are, number 1, being ignored or treated as though they are invisible. Number 2, it's being treated like they have nothing to contribute. And number 3, facing the assumption that seniors or older people are incompetent. So these are quite horrible feelings, or horrible experiences to have if you're being ignored or being made to feel invisible, you're, being seen as someone who has nothing to contribute, or you're actually being seen as incompetent. You can imagine how those words kind of make you feel. And again, when those assumptions are really what people may be expressing to others as well. And we know that 56% of older adults report that age discrimination primarily comes from people who are younger than them. So we also know that there are differential impacts of ageism as well, because we know that ageism does not affect all older adults equally. And one thing that I want to also bring up was this concept of what we call intersectionality. And it's the idea that there's the interconnected nature of social categorization such as race, gender, age, and other factors that create overlapping and interdependent systems of discrimination or disadvantage. And so this is a diagram that you'll see here that really talks about all sorts of different ways in which we can actually differentiate ourselves, for example, and all these different factors. When we think about colonialism, racism, sexism, homophobia, we'll throw in anti-Semitism as well. All of these things, for example, that all start overlapping and actually can create those interdependent systems of discrimination or disadvantage. So it's always important to think about how it's not just about age, but it can be other things that create a bit of a multiplier effect as well. So again, when we think about ageism itself, we know that it remains a problem in Canada, and certain segments of Canada's older population appear to be particularly at risk of experiencing ageism, including those who were born outside of Canada. And the NIA has now started an annual survey. We did our very first survey back in 2022, and we asked questions specifically around ageism as well. And what our own survey data found was that the experiences of ageism were worse, were more common among immigrants or first-generation Canadians, as well as those who reported fair or poor health and worse levels of income adequacy. So again, it gets at some of that intersectionality that actually can make experiences of ageism more significant for certain folks in our population as well. So what does ageism also look like when it comes to ageism in medicine and our healthcare system? We know that about a third of older Canadians report that they've experienced ageism from healthcare professionals and also the healthcare system. And health professionals often hold and are found to hold ageist attitudes. And this can fuel common stereotypes. The idea that older people might lack agency, they might be more frail than they actually are, they might be more depressed or irritable and dependent, for example. And when they're seen this way, or where we accept these common stereotypes, you can imagine that it may actually start influence how we decide what care someone might receive or overall. And this can lead to patronizing communication and invalidation of health concerns. So all of a sudden, if people are seen as being less than or other people, communication might be more dismissive in nature. For example, it might be patronizing in nature, where we almost talk down to another person because, again, they might be asking questions, and we'll say, no, this is just because you're getting older. This is not a real concern, and this is kind of what happens to you as you get older. And so all of that actually can be quite negating for an older person who might be seeking advice and support around managing their health issues as well. And the other issue is this can ultimately manifest itself as either undertreatment or overtreatment. And a number of folks are talking about these two aspects as potentially consequences of ageism when we actually undertreat someone, but they're perhaps not offering them the appropriate treatment or not treating something because we dismiss it as just a normal part of aging, or sometimes actually overtreating someone by not considering the different factors that might make overtreatment or regular treatment, if you will, not appropriate for that individual as well. So when we think about the ways in which we might undertreat individuals, one aspect could be the idea of rationing care by age, and this can this can influence medical decisions about diagnostic tests or treatments, for example. It's also about withholding resources and treatment options that wouldn't be withheld from younger patients. So it wasn't too long ago, for example, that we wouldn't actually consider transplanting or doing a kidney transplantation in a person who is 65 and older. Age was simply used as a cutoff, just simply saying that if you're older than 65, probably your life expectancy is limited in the first place, or that you'd be too weak or too frail, and that a kidney transplant wouldn't do you much good, for example. Except for the fact that if we start taking age out of the equation, and a person is relatively healthy when they are hitting that age of 65, a person who's 65 in our society will have about 22 years of life expectancy ahead of them, and the majority of those years are going to be relatively good health. So now if you're looking at a person who has 22 years of potential life expectancy ahead of them, is a new kidney a wasted option? Probably not, for example. There's also this belief, for example, around kidney transplantation that older people wouldn't fare as well from a kidney transplant compared to a younger person. Actually, the science says that older people sometimes do better than younger people on average because we take advantage of what we call immunosenescence, a natural weakening of the immune system as we age. That means you're less likely to reject a new organ than a younger person actually would. And so now, once we got rid of that age discrimination bar, and we actually now look at the individual as a human being to see whether or not they would benefit from the surgery, we know that a disproportionate number of kidney transplantations now occur in people 65 and older. A higher proportion of those getting transplanted it's a greater proportion in the 65 and older age group than that population represents in our society as a whole. So again, it speaks about that as just one example of a treatment that used to be withheld just based on the concept of age. Another issue that kind of that we bore witness to is what happened during the COVID-19 pandemic, where there was a lot of talk about, if we only have so many ventilators, who will get that ventilator, for example? And in some places around the world, they started enacting policies saying, well, if you're an older person, you shouldn't get access to the ventilator because you have probably less years of life ahead of you than, say, a younger person would. So therefore, they should actually get the ventilator. And some people might agree with that. But again, where a lot of geriatricians like myself were rather concerned was when you just simply use the arbitrary cutoff of age compared to looking at what that person's potential life expectancy might actually be, and what is the likelihood they might benefit or not from that treatment option as well. So again, it's important to think about how age itself has influenced medical decisions about diagnostic tests or treatments, and how sometimes we can weaponize it, for example, in a way that might actually lead to the undertreatment of individuals. It's also important to think about the stigmatizing nature of dementia. Dementia is something that can occur at all ages, but generally it tends to be a disease of older people, and it tends to be associated with aging. In fact, many people in our society associate dementia as a normal part of aging, which it is not. And so because dementia tends to occur amongst older people in particular, it tends to be associated with aging, and it can be quite stigmatizing as well. Because there are societal fears associated with the rising prevalence, the idea of the costs associated, and the idea that more people living with dementia will simply burden younger generations with the care and the costs associated with this. We also know that people living with dementia may experience stigma based on the cognitive, behavioral, and physical functioning challenges associated with Alzheimer's disease and ageism. So it's almost that you can get kind of a double level of discrimination where people are being discriminated because they have dementia, that people might say, oh, you have dementia, therefore you probably can't contribute to a conversation or have a say about anything that's actually important, when we know that there are various stages of dementia, and often people with a mild level of dementia often can still very much do things like driving a car, contribute to their own communities, and still very much hold an opinion, for example. But it's amazing to see when that label is actually given, how much that tends to influence their care, and unfortunately in a negative way. And so one of the things I teach my medical students is how be very careful when you throw around that diagnosis of dementia, because it's incredibly stigmatizing, and labels can kill. Because if someone sees that a person is older and has dementia, for example, they may actually undertreat them in many respects, or dismiss some of the issues that are happening as simply a normal part of aging, rather than something that can actively be treated or supported in many ways. When we think about ageism in geriatric medicine, so as you heard, I'm a geriatrician, and I'm what the New York Times actually calls a rare and endangered species of physician, because there's only a few hundred of us in Canada out of close to 100,000 doctors. In fact, there are 10 times as many pediatricians serving a smaller pediatric population in our country than the geriatricians who serve a larger population of older adults than there are children in our society. So again, the few hundred of us geriatricians in Canada and beyond have long advocated for older persons cared for in health systems that often does not adequately address their needs. And when you look at the history of advocacy from folks like myself as a geriatrician, in our early history as geriatricians, we'd often focus on protecting our older patients from undertreatment. So again, the idea I mentioned to you, how, decades ago, we used to just not even offer transplantation. Kidney transplantation is one extreme example, to anybody after a certain age, for example. And there were many other examples where people just wouldn't get the treatment that they appropriately did deserve because they were being dismissed because of their age, and assumptions that come with assumptions about aging. In our current history, it's almost that the pendulum has shifted the other way, that we are willingly able to treat all sorts of things, and almost now we're actually spending a bit more of our time protecting our older population or the older patients we serve from overtreatment when we find people on way too many medications or other things. And I'll give you some examples of both further under and over treatment in this next slide. So when we think about overtreatment, I'll give you some examples. So in diabetes care, for example, we have very clear guidelines that are set out for generally, people in general, but also specifically now for older adults. And what we actually say is that when you're an older person, you don't have to be as tight on the glycemic control. So if any of you are familiar with diabetes, some of you may have it, some of you may know a loved one who has it, you know that we focus on this number called the hemoglobin A1C, which is a measure of someone's blood sugar over time. And generally we say for a younger, robust person, for example, we might say, keep that hemoglobin A1C under 7. That's our target. But for older people, we say you can keep it up to 8.5, for example, especially if you might be living with multiple chronic conditions. Yet you sometimes still see people who are being treated for their diabetes with people really trying to target that less than 7, less than 6 number. And that might be overdoing it because that could actually cause harm, where that person might actually start experiencing more episodes of what we call hypoglycemia. In terms of drugs, for example, we often see a lot of polypharmacy. Polypharmacy means multiple prescriptions, multiple drugs, and sometimes what we call prescribing cascades, where someone is prescribed a medication and then it develops a side effect. Let's say leg swelling after someone's put on a medication for high blood pressure. Then they had leg swelling because that's a consequence of the type of medication they were put on. And then instead of changing the blood pressure medication or understanding that's the cause, a person might then now treat the leg swelling on top of the high blood pressure. And then that could lead to another issue that could be treated with a new medication. And all of a sudden, this person who just needs to be on one medication for blood pressure might be on 4 different medications to manage 3 different side effects as well. And speaking of blood pressure, we know that often in hospital settings, people's blood pressure tends to be higher, probably because they're sick and they're acutely ill. And so sometimes the clinicians in these settings are very tempted to treat a high blood pressure. And so they start tinkering with all these medications, only see that person maybe disproportionately suffer with those changes that were made in hospital, because often hospitals can be stressful places that can raise your blood pressure. There could be other things that are going on that raise your blood pressure. And often when you get home, your blood pressure easily normalizes, and therefore were all those changes necessary? So I don't want to say we should never treat blood pressure in hospital, but we need to be mindful that sometimes we could actually end up over treating people than is necessary. When we think about undertreatment, we can look at things like how we support the care management of people living with dementia. There's a lot of really good examples of things that we can do to provide caregiver support, caregiver training, but also other kind of programs and supports that can support people living with dementia that we know can significantly improve health and well-being. Yet we often don't really routinely fund and offer these services. We're more likely to pay for very expensive drugs rather than actually pay for things that we know will be much more impactful if we pursue them. And then finally, another thing that we often don't do enough of is supporting home modifications or renovations, for example, to help people manage with their disabilities. So there are some government programs that can help people pay for renovations or do these sorts of things, but often these programs aren't super accessible to the majority of the population. So one program we have across Canada and Ontario is if you actually spend $10,000, you might get $2,500 back, but who has $10,000 just simply lying around? Not everybody. We also know that that simple modifications, for example, can really make the difference between someone being able to live independently in their own homes. Yet again, it's one of those things where, is this a housing issue? Is it a social care issue? Is it a healthcare issue? And so often, because there's a lack of agreement, sometimes there can be a lack of resources that can do very small things that can have significant impacts as well. And so what does ageism look like? We also know, I mentioned how the COVID-19 exposed ageism in medicine, for example. It exposed systemic aging, as we like to say, in healthcare systems, where we saw inadequate support for our long-term care homes around treatment and hospitalizations. And I'm going to bring that word back into our presentation, where we're talking about intersectional impacts, because we know that discrimination based on sexual orientation and gender identity also compound ageism and affect the care provided to older adults in the healthcare sector. And so we know cultural, religious, and language barriers also contribute to limited access to healthcare services and poor health outcomes for individuals. And so when we think about disparities as well, we can think about disparities in clinical research and trials, because we often know that older adults are often underrepresented in clinical trials, leading to a lack of information on the benefits and risks of treatment for this population as well. And so again, how do we make sure that any research that we're funding is age inclusive, for example, because often you'll find that a new medication is being approved. It's largely meant for older people, but it's been tested in younger older people or young people in general. And so we're not 100% sure how an older person might react. So again, we often talk about how older adults are often underrepresented in clinical trials, especially around medications that often they're going to be the #1 consumers of. Finally, I want to talk about the psychological and emotional impacts that ageism can have, because it can perpetuate or create negative self-perceptions, that idea of internalized ageism. How many times have you heard your colleagues or friends or your parents say, I'm too old, they would never accept me because, I'm old and maybe I'm useless, maybe I don't need these things. Social isolation, people can become more isolated, for example, when they're being discriminated against. This can have significant impacts on people's individual mental health and well-being. It can actually erode trust in providers. If you feel that there's a provider who doesn't have your interests at heart, might be simply dismissing you because of age, then this can really erode trust in the providers that you may be working with. And finally, this can may lead to disengagement and also diminished engagement and access issues as well. So people don't feel that they're being valued or supported. Why would they want to engage with the system? Why would they want to potentially do things that and work with people who may not have their best interests at heart? This is just one of these things I found on the internet, really kind of, again, that idea that, that people have a shelf life, that after 65, that's your best before date, and after that, you're useless. And we know that's anything but the case. But again, this is kind of a nice image showing how this really does impact people in a number of ways. So what can we do? I mean, some of the things that we can do are really challenging assumptions. We know that while 89% of Canadians associate aging with negative outcomes, such as being alone and losing independence, we know that older Canadians report a greater level of life satisfaction than younger generations, and 40% of those 66 years of age and older say the best is yet to come. that's encouraging because, again, sometimes if we don't actually hear the facts about how other Canadians are actually feeling, we may be missing opportunities to best support people as well. It's also important to note that 85% of the boomers want their aging experience to be very different than that of their parents or grandparents. They may have watched their parents or grandparents not have access to the same types and levels of care that they may be able to do. And that's why so many want their aging experience to be different than that of their parents or grandparents or other loved ones as well. So what are some strategies to address ageism? Well, number one, I think it's important that we recognize the disproportionate impacts experienced by marginal groups as well. It's also important to offer comprehensive education and training for healthcare professionals that challenge assumptions on aging and educate them on the harmful effects of ageism as well. And finally, I think it's important to implement guidelines for age-inclusive care and person-centered approaches to care. As well, it's important to strengthen interdisciplinary collaboration and promote more inclusive research, and specifically research on aging-related issues as well. So as I said, everybody has a role to play, and that can be you as individuals. As individuals, you can challenge your own assumptions about aging, but also about older people. Number two, as organizations, you can think about hospitals, you can think about home care organizations, whatever the case might be. It's important to value and respect older adults as both consumers and employees. Again, if older people do not feel restricted, if they feel they're being discriminated against, they can easily take the bus or take the or just move places, for example, if they really feel they're in a center where they're being devalued and not supported. So again, how do we have organizational leadership that values and respects, older adults? And finally, we need to think about policymakers, because we know it's important to collaborate and plan for an age-inclusive society as well. So again, how do we think about how this manifests itself in terms of the creation of age-friendly cities and age-friendly communities, so that the places where we live, can be designed so that all Canadians can benefit and participate as well. And so with that, I think it's our time to lead. And I'm going to, I think we now have about 25 minutes left for questions.
I have the first question, Dr. Sinha.
Sure.
I heard you speak earlier. I was at in Vancouver, and I keep quoting you when you say that our medical system is not broken. It was designed this way, and that's what we're feeling right now. Is that we just didn't design it for the demographic that we currently have. And what can we do about that?
Yeah, so I mean, again, I'm going to go back to our previous slide here. So you don't have to stare at my name. Again, it's this idea that we all have a role to play, right? I think as individuals, as members of a council, it's important that we educate ourselves to remind our politicians and other decision makers that when we designed Medicare almost 60 years ago, the average Canadian was 27 years of age, and many of us didn't make it past our 60s, for example. And so I like to always say the patients have changed and the system hasn't. We have a system that was largely designed to work with younger people, so that if you have a single issue and you need an acute level of care, you can get excellent care in a Canadian hospital around that way. But again, we have a system that hasn't really been designed for older adults who might have multiple chronic health issues, for example, might have functional limitations and might need a little bit more support. So again, I think it's important for organizations like yours to think about understanding these issues, knowing that we have to campaign for more age-inclusive kind of policies and practices as well, so that we aren't unnecessarily discriminating around age. And a classic one was the pandemic, how we quickly started seeing where our priorities really lay, and how I often think that a lot of the unfortunate loss of life that we saw in our long-term care settings was because people didn't really look at this population as a population worth saving. They felt that this was an old population that was past their prime. There's that intersectional aspect of people living with dementia as well, people who can't actually raise their voices as easily because it might be harder for them to advocate for themselves. So it's largely their families and friends who, for example, were raising the alarm, talking about what was happening as well, along with clinicians and other people. So really important for us to kind of, again, really highlight, educate ourselves where the challenges are, really champion the fact that that we really should be age inclusive and respectful to the differences that exist, and better support people from that perspective as well.
Okay, I have a few questions in the chat. I'll ask
Sure.
2 of them at one time. How do I actually talk face-to-face with my young new GP without getting fired? And the second question is, in the hospital, when is one considered an older adult?
Yeah, so it's a great question. So I'll start with the second one. When is a person considered an older adult? I think generally, we kind of we use the traditional age cutoff of 65 as being an older person, and that's kind of geared around a few different things. If you live in Ontario, then our health insurance plan called OHIP, for example, it recognizes that as a geriatrician, I can bill for people who are 65 and older, for example, if I'm asked to see them. I can bill for seeing a younger person if they have something like dementia, for example. So 65 is considered the traditional age at which, we think about people being older. But I can tell you that in the hospital, you see 45-year-olds who are sicker and frailer and don't look as well as people in their 70s or 80s, for example, that I see as well. So age is really, in many respects, just a number, but that's kind of the general delineation that's been used in a variety of government policies and programs to differentiate between older age and younger ages. In terms of that first question, as an older person, how do I avoid getting fired by, I think it's by my younger doctor, right? And so it's just a challenge, right? Because again, I think it can be, again, it can be really challenging. I'll just remind you that a lot of family physicians may not have received specific training during their family medicine training or even in medical school around geriatric care. So currently, no Canadian or no Ontario medical school requires training in geriatric medicine. So that's number one. So I can't blame medical students for graduating without the same grounding in geriatric care as they would get around pediatric care. That's changing. U of T, for example, is finally going to start allowing us to train half of the graduating medical students in geriatric care, and in future, we'll eventually be teaching all the University of Toronto medical students. That's good news. The new medical school that Toronto Metropolitan University is creating, one of their core areas of focus is going to be around aging and diversity as well. So, remember that your primary care provider may not actually have had adequate training in caring for older adults. So they may not actually appreciate what they're seeing or what the issues might be. Sometimes there are primary care providers who say one issue, one visit, right? So I only want to hear about one thing, not a whole bunch of things. And I think it's important. You might, as you're getting to know your physician, you can politely ask, right? Did you get any additional training, or did you pursue any additional training in caring for older people, for example? You can ask them and say, often I have multiple issues or concerns, and it's kind of hard for me to work within the one visit, one issue kind of category. Is there a way that we could book a longer appointment, for example, so that we could get through issues? Often what I do recommend my older patients do, because sometimes it's hard. If you haven't gone to medical school yourself, it may be hard to determine which is the number one issue that I should be discussing with my primary care provider. So I often encourage people to write a list write down their concerns ahead of time, so that if you do have someone, if you do have a physician who might be prone to one issue, one visit, for example, you can share with them the list, and they might work with you to pick, well, actually, I know that, your top 2 issues are 1 and 2, but I'm most concerned about number 3, because that might be more potentially life-threatening. But you know what, maybe what we can do is let's address that and maybe book a longer appointment so that we can discuss all these things together. So those are just some of the things that I think could be helpful for you to help navigate potentially what you might worry is a potentially challenging relationship. Go to the next question.
How often are older adults consulted and included in policy making around ageism in medicine?
I would say not. I would like to say most of the time, but I'd say probably most of the time they aren't. For example, I think it is not like, I always try to include older people and caregivers in the work we do. When we developed the new national long-term care standards, we were required by the Standard Council of Canada to have 1/4 of the seats on our technical committee being held by either family caregivers and or long-term care residents, for example, people of all ages. And again, think about that age discrimination or that ageism that we have, that reverse ageism. We had a long-term care resident who's in her 40s. We also had a long-term care resident in their 90s who is a member of our council as well, or our technical committee. So again, it's important to have appropriate representation and not discriminate around age either way. And if you don't see a situation where older people are being consulted, you might want to talk to the organizers and say, why don't we have that perspective there? That could be very helpful to prevent any ageist kind of views or beliefs as well. So I think we should be doing more to actively consult older people, but it isn't, I wouldn't say it's the standard practice, but I think people are increasingly recognizing the value of having older people involved in making decisions around their own care.
Okay, great. I have a question about long-term care.
Mhm.
Will there be any significant, I know you didn't talk about long-term care today. Will there be any significant changes in the long-term care in the near future, or does the whole system need to be overhauled?
Yeah, so I mean, I think the challenge is that right now we have, kind of each province and territory runs their own individual long-term care system, and I think many provinces have now had reviews or inquiries that have really pointed out common issues of concern that do need to be addressed. We need to have better staffing, for example. We need to have better pay of people who are working in our home and community care and long-term care sectors, for example. We need to make sure that we have better standards of quality and better enforcement around those issues as well. What's heartening to see is when you look across the country, there are various jurisdictions. For example, Manitoba did a review, and they have been progressively implementing each of the recommendations of the report they received. I know Alberta has done a wholesale review and is moving towards a whole new model of long-term care. The idea of using the small house model, small long-term care home model, as opposed to these big impersonal settings where often people might be living multiple people in a room, and that's a recipe for a lot of spread of infections as well. So there are, and the federal government, to help facilitate a more transformation at the front lines, has put out $3 billion to support provinces in being able to implement, more closely the new national standards for long-term care. So there is work that is happening. I'm heartened to see that some provinces are making more substantive moves to kind of bring their own standards in line with the new national long-term care standards. So I'm hoping that all of that together will start to help people see how a meaningful difference is being made in long-term care settings by improving staffing and better supporting them, as is outlined in the standard, to be able to provide better care.
So I always have to say this. My parents live in Manitoba. I mean, they're passed away now, but there was 56 hours of home care provided that wasn't income tested, that was self-managed, and the care was unbelievable. It was fantastic. Like, I mean, that's such a success story. And when you see how well that works, it's hard to see what's happening in BC with home care. But currently, you talked about frailty, and there's no provision like to help frail adults at home to get proper pain medication, proper antibiotics. Like, they have no choice but to admit themselves in the hospital. Do you think that will change in the near future?
I think so. I mean, I think what we're seeing is increasingly, other governments that have really kind of done a much better job of caring for their aging populations, or countries like Denmark, for example. Back in the late 1980s, they actually they actually embraced a whole new policy, or a series of policies that really shifted the focus of long-term care services towards community care provision. Because it's a lot cheaper, you don't need all the infrastructure costs, but it was more in line with what people wanted. And when you look at the types of home support, that are being provided in Denmark, for example, it's not just traditional home care as we know it, but it's also this idea of home supports, for example. So help with, gardening, help with housekeeping, but also help with taking medications and other things. Some of that is being provided depending on where you live in Canada, but it can be very hard to come by as part of the publicly funded system, but those things do make a difference. And so I think increasingly we know that the level of home care services significantly varies. We have about 15,000 Canadians or Ontarians who are on the wait list for home care in this province alone. We have wait lists in some other provinces as well. But then overall in Canada, about 430,000 Canadians report having unmet home care needs. And so one of the key things that and so you don't have to be a rocket scientist to appreciate why there's over 52,000 Canadians who are on nursing home wait lists, because if you can't get adequate home care in the community, then it becomes very hard to be able to stay in your own home for as long as possible. So so there are things that we need to do, and I think increasingly we're seeing some governments kind of look at this. The other thing that's happening right now that some of you may have participated in are the Aging Well at Home consultations. The federal government announced during its last election that they would work towards creating or examining the creation of a new Aging Well at Home or Aging at Home benefit for older Canadians. And so I'm on the National Seniors Council that's serving as the expert advisory group for this work. And I think it's really important to understand that, because I think it's it's helpful to see that we're starting to think about what are other things we can do to enable people to, as we like to say, age in the right place as well. So I do think that there is growing recognition about the need for a variety of services, not just and more of those services in home and community care settings, so that we can better support people to age at home for as long as possible.
Another question, is there a dollar value to have the perfect system or a better system? What would it require an investment, like in terms of the tax? Do we know those numbers?
Yeah, so right now in Canada, we spend about $38 billion in public funds on the provision of long-term care services. That's home and community care to nursing home care. The vast majority of those dollars in Canada, about 2/3, are spent on providing nursing home services or long-term care home services, for example. About $12 billion, so adding up to a total of $50 billion. So about $12 billion is spent out of pocket by Canadians and on co-payments and or buying care privately outright, for their loved ones. So it really shows you the scale of what we're spending. But Canada as a whole is, it doesn't spend as generously as other countries do. So where we spend about 2% of our gross domestic product on providing long-term care services, if you go to countries like the Netherlands or Denmark, for example, they actually spend about 4% of their GDP, about twice what we actually spend on the provision of long-term care services, for example. And while their spending on long-term care is a greater proportion of their overall healthcare budget. Their overall healthcare budgets per capita are smaller than the Canadian overall healthcare budget per capita. So they're just, by simply investing more of their healthcare dollars in providing care at people's own homes, they're actually showing that that actually saves the system money overall. And it means that less people will be living in hospitals waiting to go somewhere else because there's more home and community care available in the first place.
I know I'm answering all the questions, but most of your questions in the chat have been answered. So
Okay.
really, if as a country we spent that 4%, we up to 4%, it wouldn't just improve care for older adults, it would improve the system for everyone, all ages. Is that correct?
Absolutely. So we just recently made there's a national prize for health policy that was just announced earlier this year, and they said, "What's your one big idea? What's your great policy change?" And we just said, just provide more home care, because frankly, if more people can stay at home, then you wouldn't, if we address the issue that 430,000 Canadians have unmet home care needs, I can tell you we wouldn't need to have 52,000 people on the nursing home wait list. I think, Rochelle, you mentioned how your parents were able to access 56 hours of home care a week in Manitoba. I don't think it's that generous anymore, to be honest, than it used to be. But, when you talked about it, you're like 56 hours, wow, that's like, that's almost 7 hours a day or 8 hours a day of care that someone receives 7 days a week. That's a lot of care. That's actually kind of what Denmark can provide as well, for people who absolutely need it. And you can see that really would help people stay at home longer. But when some of my patients only get 1 or 2 hours of care a day or a week, for example, they're on the fast track to being institutionalized. So again, we can take pressure off our long-term care homes. It's not to say that we'll never need long-term care homes. We'll absolutely need them, but we might need them a lot less. Because even CIHI notes that 10% of the people who are currently in our long-term care homes are being admitted could have probably been supported at home with existing home and community care services. So that's part one. But imagine this now, 25%, or at its worst, 24% of the people occupying Ontario's hospital beds were ALC patients designated alternate level of care, largely older people who were mostly waiting not for a long-term care bed, but to go back to their own home with government-funded home care. But when we just didn't have enough, people end up getting stuck, or as my Danish friends say, they get held hostage in hospitals. So they're being, held hostage. They want to go home, but they can't go home because the care isn't available in the community that they need. And so people just languish in bed and stay in hospital beds longer than they need to be. But imagine now, you had adequate home care, you had adequate rehabilitation services, you had adequate long-term care home spaces, then all of a sudden you could actually really, really improve hospital efficiency, because you would suddenly not have 1 in 4 of your beds occupied by somebody who's trying to go somewhere else, for example, and just simply waiting there. So you can start seeing the value of that. And then when hospitals aren't overrun with patients, for example, they have more capacity to do more elective procedures like hip and knee replacements and other things. So you can see how all of this is really interconnected, and why better care and more proactive care for older people can certainly benefit all of us as a society as well.
Okay, so I see it's 3 minutes to 11. We're ending at 11, correct?
Absolutely.
So there's one last question, and then I just need 30 seconds near the end.
Sounds good.
Do you see a concrete way in which an institution like ours can advocate successfully for this issue?
Absolutely. So, I mean, I think if you go to our website called www.nationalseniorsstrategy.ca, I'll enter in the chat during your closing remarks, Rochelle. At that website there, you can actually get more educated about these issues as well. We have 14 evidence briefs that really help deal with a number of different issues. For example, they give you the facts, they give you the figures, they give you the information that you can advocate around that resonates most with your organization. So, get involved, in terms of learning about these issues, and then see what makes sense to resonate or to advocate around as Jewish women. And I think this is the opportunity that's in front of you. And so I welcome your collective advocacy and support because it can really help make a difference.
Okay, thank you. So thank you, Dr. Sinha. First of all, thank you for the shout out about Mount Sinai Hospital. I didn't know that, or maybe I did, but I forgot. But it's important to remember that the seeds planted today, the trees planted today provides the shade for future generations. So we have, you know, even though we don't feel the impact of our work, it's important to do the work. Thank you for the data that's provided by the NIA. I mean, that data is so important because it really helps our work and our advocacy work, especially wearing my other hat at the Jewish Seniors Alliance. And then Dr. Sinha, I've listened to so many of your YouTubes. A friend said you're her hero. So thank you for your passion and your commitment to this topic.
My pleasure, everyone.